the previous urologist.
Today we are discussing the prone supine semi-level model, where the advantage of prone and supine PCNL we will discuss.
Primarily, for last
decades. Sorry for the inconvenience. There is some resound. We will settle this and then come back.
it comes on.
Go and check whether this transmission is coming or there or not, whether my sound is received or not. So for decades, Prone PCNL is there last 60 years. Supine PCNL was there in 1970s. Now, after the RIRS and ECRS, Supine PCNL has been done. So, in which case supine PCNL is useful? In which case Prone PCNL is useful? In which case Prone PCNL is less useful? In which case supine PCNL is less useful? We will discuss about it. For the discussion, actually, I involved Dr. Rakesh Panda, who is a consultant with us, who has seen both the prone and supine PCNL in our evaluation, and he has keen interest in evaluating each case, and he has selected some cases also. Let us discuss on the table how the prone and how the supine approach is done. Now, LKCB Medical College, Odisha, is from of India. Fellowship in Urology and he got urology. So he now we have an interactive session. Perspective. One patient, the prone position, we should thank them, both of them, and one is in the supine position. There is a sciam here. Now, Rakesh, I wanted to ask you, what is the main difference? What is the main difference?
Thank you, sir, for giving me to talk about case scenario between how to supine and PCNL. So, coming to the basics,
Voice is not coming. Right? You just check your phone, if you how it is coming. Okay.
so the basic difference between prone and supine is apart from position, the patient, the main major landmarks in prone PCNL are paraspinal and iliac crest. Whereas in supine PCNL, posterior axillary line is the landmark, and this iliac and protrude remains the same. Here we have large flat PCNL, whereas here oblique and small area for culture.
When you keep the needle on the surface of the prone PCNL versus on the surface of the supine PCNL, can I have needle? So, if I keep the needle on the surface of like this, and when I keep the needle like this, what is the main difference?
Major difference, it looks longer.
Why?
Go to oblique.
So,
You keep the pulse,
just and lot of
It's seen.
is seen as if you are putting entire needle into the body. That is the major part. And the other one is exactly you wanted to measure. That's it. That is the
The spike will not come in supine this prone.
stone piece. Because it is horizontal, the medial end will never come onto the spine.
Yes.
Whereas here, sometimes it will be opposite to the spine also. For example, more like this, this even though it is coming onto this kidney, it may look
Beyond the spine.
beyond. So I wanted to ask a primary question. If there is a pelvic stone here, for example, give me a coin. There are clinical scenarios we discuss. Imagine this is a coin which is present in the pelvis. Like this, it is present in the pelvis. So it has access to the upper pole, it has access to the middle pole, it has access to the lower pole, ureteric catheter is kept. And the same thing, you are having a pelvic stone here. In this case, what will you prefer and why?
So for a pelvic stone, there is no much difference between supine and PCNL. We can access different anatomy. In prone PCNL, either we can come from inferior or middle calyx depending on the RGP, and the same can come from either inferior or middle calyx.
Is better.
Yeah.
Okay, right.
So we can come either from the inferior or middle calyx in supine vision also. So there is no much difference.
Yes, a scenario. Number one, in the pelvic stone, large stone or small stone. We can approach from the lower calyx. You can approach. So in prone, normally what calyx you prefer?
So in prone position, the patient lies flat. If we are planning to, there is a stone in the
Pelvic
inferior
stone
calyx.
is there. Will you prefer inferior calyx or middle calyx or upper calyx in prone?
Inferior calyx or middle calyx.
Supine, which one is preferred?
Middle calyx is preferred in supine position.
So that means if a pelvic stone is present, here you have two options, middle and inferior. Here you will have to go for
Middle calyx.
that is the most important part. One option, calyx you can go, but if it is projected, let if we have a stone, if you, the kidney is like this, kidney is like this, and the ureter is like this. So you have upper pole, lower pole, mid pole. If you have a lower pole stone, if you have a lower pole, here also the kidney is like this, your lower pole, your mid pole, your upper pole. Now, your lower pole stone here, okay, lower pole stone here, you have lower pole stone here. What will you prefer? In a prone PCNL, supine piece, pole large stone.
So for a inferior calyceal large stone, I will prefer prone PCNL.
Why?
Because I will go at an angle of 45 degree, and this iliac crest will not hamper my movements. Whereas here, if the calyx is parallel to the ureter and medially facing vertically down, then this iliac crest will hamper my movements. For each step, for dilatation, for puncture also, it will hamper my movements. So prone PCNL is better for any single inferior calyceal.
So is it clear, Prem, for all inferior calyceal stone, unless it is projecting lateral, unless alone inferior calyceal stone, large stone, prone PCNL. Whereas supine, if you wanted to do, what keep it straight. Now by keeping that, what happened?
This iliac crest moves medially, we got some space to move.
Yes.
And if the calyx is more laterally faced, then also we can do the stoning to patients.
Okay. So for all practical purposes, if you are doing only inferior calyx, the leg has to be straight, ureteric catheter will be there, RIS hole will not be there, And if the leg is preferably, we can go to that side also. So, surgeon. Whereas in prone, you directly go like this, so this part will not come into big picture. Now coming to the middle, your middle calyx, here middle calyx, hold it. Now in prone PCNL, middle calyx, in supine PCNL, middle calyx, single stone, no bifid system, no trifid system, just middle calyx stone, large stone. Which one you prefer?
So suppose there is the middle calyx stone in posterior calyx, posterior middle calyx.
How will you identify?
In free of CT, we can know whether the stone is in anterior calyx or posterior middle calyx.
Okay. So
Suppose
if the stone is in the posterior calyx,
stone is better.
directly will go to the most to attack the
Posterior calyx.
attack the anterior.
Very difficult.
Very
We have to come.
ideally not.
Ideally.
Need going vertically down to reach the anterior calyx, you have to cross the calyx.
Yes.
It is cross calyxal function.
Bleeding will be more.
Bleeding will be more, or else you have to go laterally. Whereas in supine,
Supine PCNL, the puncture is horizontal.
horizontal.
Parallel to the
Can you
ground.
show that horizontal puncture like this?
The wheel puncture like this.
Yeah. Heel puncture like this.
Horizontally. At the last moment, we can change the needle
How will you
direction.
change it?
Just and we can change.
So for middle calyx stone, which
Supine PCNL.
advantage, because whether it is anterior or posterior, you are going horizontally. In the last minute, you can go horizontally up, or you can go horizontally down, and you can take entire periphery of the kidney is in your view. Here, entire posterior surface is in your view. Here, entire surface is what Broding's line. So very safe. So last minute you can change to posterior. Can you change from it's only one direction, then anterior? So because you are coming from posterior. Now upper, for example, supracoastal region, upper calyx is there like this here. Here also supracoastal is there. Here. How will you approach?
If the coming to prone PCNL single superior calyxal stone, we have to see if the kidneys, especially left sided, it may come above 11th rib. Then we have to come little to the periphery and do a peripheral part intercostal puncture. We can clear the stone, it will be a vertical puncture. But coming to the supine position, the kidney posterior pole is the superior pole is posterior. So what is here? Here.
So what you have to do?
We have to tilt it little more.
Patients like this.
Yes.
Then what is the disadvantage if you turn supine PCNL?
Spine interposition.
Spine interposition will. So here you will be supracoastal. Also you will be supracoastal. Here directly you will go posterior calyx with minimum track. Here you have to go lateral with a little bit of longer track. Here you will attack the posterior most part of the calyx. Here you will attack the
Peripheral part.
lateral part of the calyx. Here the lateral part of the posterior calyx. Here superior part of the calyx. So in your choice, both are same, but one choice even vertical bullseye you can go most medial posterior stones. Whereas here most medial superior calyx stones very difficult to go through. So given choice, do you like to go in superior calyx stone?
Prone PCNL in superior calyx stones.
Prone is there. So to conclude, pelvic stone you prefer prone and supine. Inferior calyx stone, prone is better. Middle calyx stone, if it is posterior, if you don't know, supine is better. If you have posterior calyx, you can go for prone. And superior calyx is better. But you can do in supine also, but tilt of the patient will be more. Now, combination. Okay. So in combination of the patient, you have a pelvic stone. Imagine you have an inferior calyx stone.
Yes.
Same thing, two kinds, please. Imagine prone and compare. So, for example,
Nice.
so in if you say points, we have one the oh no problem. Right. Okay. Like you have one pelvic stone, one inferior calyx stone. You have one pelvic stone, one inferior calyx stone. How will you approach?
Coming to the same advantages and disadvantages of inferior calyx.
Inferior calyx, correct.
So this iliac crest will come in the view. If I am doing, there is no lateral part of the calyx.
Can you go from the middle to pelvis and then turn here? Difficult or easy?
Difficult.
Why difficult?
Because we have to come from up to below to upper.
Below to upper.
Below to upper is
Because the middle calyx is here, inferior is here. Here, inferior calyx stone is here. So you have to look
upper.
up. So you come from calyx to pelvis and then look up to the. But if you cannot look,
Then we have to take
you have to puncture. So here you puncture inferior calyx, you look down. Why? This inferior calyx is more anterior here.
Yes.
If you puncture here, rest of the things you have to look up only, but manageable. Because this iliac crest will not come into picture. Do you agree on this?
Yes.
So inferior calycial stone is always a disadvantage to supine PCNL. Inferior calycial plus pelvic stone is also a disadvantage to supine PCNL. So more, but if inferior stone is small, for example, there is a small stone, there is a big stone here.
Then we do it by this. We will come from
Okay.
and we can try to negotiate with.
If fails,
we can take help of flexible stroke.
PCR. For example, here small stone is there, very small stone. Coming in prone PCNL through this, that small stone may not be easy. So in that case, out the stone, take out this also. If it is not coming, you put soap and take it out. So for all practical purposes, inferior calycial stone is a disadvantage for supine PCNL. Large inferior calycial disadvantage for supine PCNL. Small inferior calycial stone better for supine or prone. If you are comfortable with PCIS, do the major stone for middle calyx. Majority of the PCNL surgeons will not accept for ECIS. It will add cost. And one more surgery is required. For small stone, why you want it to take it out? You agree on this? Now, coming to the second combination, pelvic plus middle calycial stone. Pelvic stone plus middle calyx. You have middle calycial stone. How will you do?
So say if you don't know the anterior and posterior calyx, then supine PCNL.
So if the middle calyx there, pelvic stone is there, supine PCNL is very good because you will go in line with it. The needle will move the calyx. Nicely, you can go to anterior and posterior. You remove this stone, you remove this stone easily. Whereas here, by chance, if you go to the middle calyx, suddenly you may not be able to go sometimes to the pelvis. But that most of the time is good for supine, except anterior calyx and may not be easy. If they don't come in, long. Not so benefit of doubt, which one you prefer? So supine PCNL. Now coming to the pelvic stone is there, upper calycial stone is there. Same pelvic stone is there. Sorry, same cluster level, same pelvic stone is there. Here upper posterior surface like this. Like this it will be there. Like this. What will you prefer then?
If the stone is
yeah, if a large stone is there in the superior calyx, you will prefer the prone because
then we can come from the middle calyx and we can always it is usually we can reach to
you can see in go to upper,
yes.
but such a small stone, why to take supracostal?
Yes. We can
But such a small stone, why to take supracostal? You negotiate. Take. So always bring development. So to conclude, large inferior calycial stone as large pelvic stone from this. Large middle calycial stone, larger stone, large superior calycial stone, large pelvic stone from this. Small stone and large pelvic stone, both are available. Small middle stone, large pelvic stone, supine PCNL. Very small upper calycial stone and large pelvic stone, supine PCNL. Now combination of three. Now we have a pelvic stone. You have a inferior calyx, have middle calyx. Now all the three are large. Then what will you prefer?
Then I will prefer prone.
Why?
Depending on the RGP and anatomy.
Yes.
Either I can come from the inferior calyx or middle calyx.
Okay.
And I will be able to carry maximum volume of stone.
Mm.
Then If the middle calyx is not reachable from lower to middle, then I can do as the 7 plus technique, or else extra function maybe.
Extra culture good. See, I differ with you because I am doing supine PCNL more. What I try with the middle calyxial stone and I remove the middle calyxial stone supine and I remove the pelvic stone and I will try to turn from middle calyx to inferior. If it is larger than an obtuse angle, I can remove that. Or else, prone PCNL. So, other if inferior prone is good, supine is also good. In prone, you try to puncture inferior calyxial stone, go to pelvic stone, turn it, and then remove. If you cannot turn, he is saying that you do saline flush and then remove. Or else you dilate and push this here and remove. In supine, you go through the middle calyx, remove this, turn here. If it doesn't come out, you have to come another puncture from the inferior. Ultimately, middle calyxial puncture and removal of the stones is very good in supine piece. Now, same combination, if it is upper calyx, middle calyx, and pelvis, and large stones are out there, what will you prefer?
I will prefer prone piece.
So, all large stones in the upper calyx, slight preference to prone is there because you will reach the most posterior part. Anyway, it is proportional.
Yes.
Here the track to travel is very less because you will be going vertically down directly to stone. Here long track will be there horizontally to reach the stone. So in this case, you go to upper calyx, remove it. You go to pelvis, remove it, and then remove it. Whereas here, if you go through the, it will be like this. You have to go, but from here to here is okay. From here to here, coming down is difficult. So there is no point doing PCNL if a large stone is present in the bar. Now the discussion important arises. Now you have a pelvic stone. Very small stones are there in the middle and upper. What will you do?
Supine PCNL better.
Supine easier. You do medical puncture, remove this, take flexible scope, and take out all these stones and bring it to nephrostomy tract of the middle. You can come from below here. You can, voice is not coming. This is off channel. Voice is not coming. Huh? Now, we'll continue. If the stone is in the pelvis, two small stones are here. So you come with the middle pelvis and remove the stone, and these two stones you can remove with the flexible process.
I can go with small microscope from middle that you.
Yes, if you cannot. So small stones is a large because for small stones you cannot consider in prone PCNL. So now coming to the saga in the pelvis, you have a stone in the inferior case, you have stone in this. Now what will you prefer?
Dragon stones, I will prefer prone piece.
Prone PCNL.
I will come from superior calyx.
Superior calyx you come, you take out the pelvic stone. Bifid system is not there. If bifid system with small stones are present, find this. Whenever small stones present in different cases, supine plus small stones and when large stones are present, prone PCNL is fine. If you don't want to require ECRS, it's okay. If large stones are not there, ECRS, okay. You can put one more
Function.
So now coming to the what are the now we are talking so much on supine. Now if you discuss all the cases, more tendency towards which side we are
prone PCNL. Because we are used to it, we can remove easily, the length of the tract is less, and special training is not required. Here, posterior axillary is variable. That's why I said that what is the other landmark you say? Tip of the 12th rib. If you take tip of the 12th rib but 2 fingers below, you will be very safe. But still, these landmarks are slightly variable. And second thing is, you can sit and do. That is the advantage in supine PCNL. But radiation is also less in supine because you will be here. In prone, you will be here, nearer. In supine, you will be here.
Yes.
Nearly small distance away from the C arm. And coming to the supine PCNL advantage main is the flexible scope passing. So whenever there are small stones, you will have advantage of ECRS. So ECRS, supine PCNL apart from the stone location, where do you prefer?
If the patient is having any cardiorespiratory problem,
see, every patient cannot be turned back easily. 150 kg patient is there, severe breathlessness is there, airway control is very difficult. If somebody can do from the supine, it is better.
Yes.
Next,
if any dismatter pyelonephritis patient with destabilized cardiac, BP less BP,
emphysematic pyelonephritis,
we can do supine puncture, PCNL we can do.
Supine PCNL we can do.
Other biped or triped system with long narrow infundibulum. We can avoid extra puncture.
The long narrow infundibulum RIRS is better. Even if the stone is little bigger, what can you do? You can make pieces
and give it to the
nephrostomy tract. Number of the tracts will be less. So multiple long infundibulum, multiple stones. What will you prefer? ECR. ECRS means invariably supine PCNL. Whereas in prone PCNL, all large stones, all radiopaque stones, it is directly you can puncture, there is no harm. 2-3 punctures also you can do, there is no harm. What are the other cases where supine is used?
In kyphoscoliosis case.
If patient sleep only in supine, some patients go in prone. But if the patients sleep in only supine position, it is okay, no? If the patient is only in supine position, you can do kyphoscoliosis patient. Anything more?
One more thing is,
one you told, very obese patient. Another is severe. Another is emphysematic pyelonephritis. Next,
long narrow with
long narrow infundibulum, bifid system, trifid system, small volume stones. RIRS is very useful combined with supine. Okay.
One more case is single functioning kidney is there. We want to avoid multiple puncture and recurrent stone form. Then we can with supine PCNL.
Large volume you remove from the middle kidney, and all small volume you put nephrostomy, and you do nicely with the RIRS. So pressure will not raise. Solitary kidney with multiple stones, recurrent stone formers is a very good indication for ECRS or only RIRS. First is only RIRS. Second is ECRS in supine. Up to small tract. You can use laser and take. Naturally, you should not dilate. Solitary kidney you should not dilate left and right. Next,
if small stones are there in all the kidneys, means 1.5 centimeters, not that big.
See, not that big, not that small. If small are there, you can do RIRS. Big are there, you can do whatever. If 1 centimeter 5 are there, what will you do? You take out all the 5, put in the pelvis and do middle calyx and remove. Absolutely, supine PCNL has advantage along with ECRS. So in supine PCNL, if the ureter is not tight, ureter is not accountable, then can you do ECRS? You can't. Then all the advantage of supine PCNL goes.
We have to depend on.
You have to depend either prone or else put the stent and do RIRS after. Till that time, can you keep PCN? Generally, we don't. So if you remove the PCN early, RIRS when can we do? 2-3 weeks. 3 weeks we have. So that is a discussion. Now with this, can we go to the cases? So now we discussed here, middle calyceal puncture is very easy in supine PCNL. Middle anterior stone is the absolute this thing. Some stones cannot be done with supine or very rare.
For superior medially located.
Superior medial, for example, if the stone is here, superior medial, how can you go from here, going here, going here, going here? It may traverse. Whereas if it is superior medial here also, one vertical direct puncture onto the stone, feel it and just take it out, it is fine. There is no problem. There is no problem. You got the point. So most medial superior calycial stone, most vertically directed stone, most superior vertically directed stone, supine PCNL is not possible. One question: if the ureteric stone is there, from supine or prone, where you can reach the middle calyx easily?
Supine PCNL is better.
Better, because supine middle calyx to upper ureter is easily approachable. Infracostal, at the same time,
And sometimes you can reach up to mid-ureter.
up to mid-ureter also you can. To reach mid-ureter in prone, where you have to puncture supracostal, superior calyx. Then only you can go down. Whereas here from middle calyx, ureter easily. That is the advantage. And usually in prone PCNL, which calyx to go in all other calyxes?
From superior calyx, we can go.
If you are not afraid of the supracostal puncture, reaching all the calyxes for superior calycial puncture is easy.
Because we look down on.
We look down because most superficial is the superior calyx. Then you look down everywhere. Here you look down where you will puncture spine anterior. But is it easy?
Not difficult.
It's difficult. If you can puncture inferior calyx, all the stones can be removed.
Because
if you can puncture superior calyx, all the stones can be. Here it is the supracostal. Here it is the iliac. Both way we are this thing. So lower calyx, if can be reached easily with supine PCNL, you can remove all these stones. If you can reach the upper calyx easily with prone PCNL, you can reach all these stones. Here it is supracostal is the problem. Here is the iliac crest is the problem. Here, if the calyx is directed laterally, then it is easy. Here, if the calyx is little bit below the 12th rib, it is easy. So here, if the kidney is down, it is easy. Here, kidney is up, it is easy. Kidney is up, supine PCNL, lower calyx is punctured. If kidney down, superior calyx is there. So that also we have to see when in RGP, if kidney is very low and inferior calyx is coming onto the iliac crest, you should not do prone. We should choose. You should not choose supine. So should we discuss the case scenarios? Can we switch over to the you present? I will discuss, and we can. You have separate laptops.
Yes.
Yeah, I have the laptop and he has laptop. He will present the case scenarios where his opinion whether prone might have been better or supine might have been better. He will explain so that this discussion will be useful. We should thank both of them. What is your opinion? Rohan and Bharat, thank you for cooperating. I appreciate we have not used among them because technically we have not discussed. One more thing I wanted to ask you, very important question, lot of people ask her. In prone PCNL, this CM is there. Now get take out this. Yeah. It is important. Turn back. Come back. Now, in get the CM, you will not do much, don't worry. In prone PCNL, when the needle is kept like this, 0 degree. It is 0 degree. What are the things you will get information?
0 degree, we can tell whether the needle is up and below.
Up and below.
Medial or lateral.
Medial and lateral. Depth, can you tell?
No, we
No.
can't tell about that.
So, if you keep the needle, normally in prone PCNL, how this CM is tilted?
30 degree,
30 degree towards the, what is this receiver?
receiver.
Where is the producer?
Here.
Here.
That goes
Rays
away.
will be produced, rays will be received by here. So normally in prone PCNL surgeons, this you go there and show, this will be
30 degree
30 degree towards me. What will happen if the needle is more posterior? Will it go away from the spine or towards the spine? It will go towards the spine. That's all. For example, if this needle is there, if it is going towards the spine, it is more superficial. That means more posterior. If the needle goes away from the side, your is on the back, anterior side. So, CM, prone PCNL, 30 degree upper head towards the surgeon. After the puncture, if the needle goes more towards the spine when compared to the stone, it is posterior. If the needle is away from the spine, in comparison to the stone, you are more anterior. Clear? I will repeat again. In 0 degree, you have punctured, you wanted to see the depth, you turn the C-arm to 30 degree towards your side upper receiver end, then see the needle. If the needle goes towards the spine, you are posterior to the stone. If the needle is away from the spine, your needle is anterior to the spine. Withdraw and go more posterior. Now, coming to the supine piece. Supine piece, what we do is, now we puncture like this in supine piece. Medial lateral will be seen in 0 degree. Inferior 0 degree. But what you said is depth is not seen. Now, usually surgeons wear this towards the head. Can you show that towards the head? Like that you will tell. What will happen if the needle goes up in the screen, top, when compared to stone? What does it mean? Posterior. That means this side you are, back side you are. You have to go more anterior. If the needle goes in the down part of the screen, you are more anterior, dangerous. Anterior, you should not be there. So needle should never go down towards the screen. Better to be away. That means first start from here, then start from here, then start from here. This is called gradual ascent. In supine PCNL, first try posterior, then go up. In prone also, first try posterior. Posterior will be superficial, so gradual descent sign. First you try here, then here, then here. Here first you try here, then here, then here. Always be on the back side. Always be on the back side. Here in supine PCNL, to conclude, if the C-arm receiver is 30 degree up, if the needle goes up, it is good that you are more superior posterior. Withdraw, go more anterior. If the needle goes down in the screen, you are more anterior, not required, go more posterior. That's all. Then two things if you remember. Generally, here, whereas in prone they did towards the subject. Either way, you can one if you remember, there is no need for of any. Now we will go for the case discussion.
Is my screen visible, sir?
No, sir.
You asked there. Not audible.
Rakesh. Rakesh, am I audible?
No,
Rakesh, don't share the screen. Rakesh, don't share the screen. Come on, yeah.
Okay.
Rakesh, don't share the screen.
Okay, sir.
Am I audible, Rakesh?
Yes, sir. You are audible.
Am I audible?
Yes, sir. You are audible, sir. Yes, sir. You are audible. Yes, sir. You are audible.
Am I audible?
Yes, sir. Yes, sir.
Speak. I am not audible.
You are audible, sir. Can you hear me, sir?
Am I audible now?
Yes, sir. Yes, sir. You are audible, sir.
Yeah. Now, first 20 minutes, there was disturbance. So we will immediately ask questions briefly. You answer quickly.
Yes,
If
sir.
the stone is in pelvis, do you prefer prone or supine?
If the stone is in pelvis, both are equal. Prone and supine PCNL both can be done depending on the anatomy. Either you can come from the inferior or middle calyx in prone position, and ideally in supine PCNL we prefer middle calyx for pelvic calculus.
So supine has only one option, middle calyx, whereas prone two options, inferior and middle.
Yes,
so
sir.
you can go for prone or supine.
Yes,
If
sir.
the stone is in the inferior calyx and very large, what will you prefer?
If the stone is very large inferior calyx, then I prefer prone PCNL. Because
Okay.
in prone PCNL, iliac crest will not come in in my movements or any step.
So
But in
prone PCNL, lower calyx is useful, whereas
yes,
supine PCNL, lower calyx is difficult,
yes, sir.
especially if the lower calyx is directed
Low lying.
vertically
But
down.
directed vertically and kidney is low lying.
Kidney is low lying, and if the calyx is vertically down, supine PCNL you should not attempt.
Yes, sir.
If you have a single stone in the middle calyx, what will you do?
If there is a single stone in middle calyx, if you have pre-op CT, we can look for whether the stone is in anterior or posterior calyx. If
If
it
you
is in,
don't know, if you don't know,
if we don't know, then better is supine PCNL. We
why?
can, because we can puncture the middle calyx horizontally. Whether it is in anterior or posterior, it doesn't matter much. At the last
Prone
moment,
PCNL, does it matter?
yes, sir. Prone PCNL, always we puncture the posterior calyx. Then going from posterior to anterior is difficult. We have to go through the infundibula of the posterior calyx. More chances of bleeding will be there.
Yeah. If the stone is in the superior calyx very large, what will you prefer?
So both supine and prone can be done in this condition, but prone is little better. We can
Why?
come because the tract will be vertically down and little less length we have to travel. Whereas in supine PCNL, we have to tilt the patient little more and we have to travel a longer length in the
And
kidney.
spine overlap also will be there.
Yes, sir. Spine overlap will come.
Long length will be there, spine overlap will be there. Can you avoid at least supracostal? That is also not there.
That
So
is
large upper calyxial stone, always prone is better.
prone PCNL is better.
Large lower calyx, prone is better.
Yes, sir.
Large middle calyx, prone or
Supine.
supine, but supine has advantage.
Yes, sir.
Pelvic stone, prone or supine, okay.
Yes,
Now
sir.
let us discuss combination. Lower calyx plus pelvic stone. What is better?
Prone PCNL is better if there are both stones in lower calyx and pelvis. We can go directly at an angle of 45 degrees to inferior calyx and clear both the stones.
If the stone is there in pelvis and middle calyx,
Supine PCNL is better.
why?
Because
Because same advantages of
same
middle calyx will be there.
Yes, sir.
If the stone is there in the middle calyx and upper calyx,
Then prone has little advantage than supine.
Same thing. If very small stone is there in the lower, middle, upper, and then big stone in the pelvis, what will you prefer?
Then supine I will prefer, sir. Because
Why?
I can come directly from middle calyceal puncture and I'll try to reach the lower calyx from there. Even if I am not able to reach, I can avoid puncture and I can take help of flexible scope. If with
ECR.
ECRS, yes, sir.
ECR. So
ECR.
if the pelvic stone with small stones in the any calyx present, slightly supine PCNL is better.
Better.
Now next combination, 3 stones.
Yes,
Large
sir.
stone in the lower calyx, large stone in the middle calyx, large stone in the pelvis. What will you do?
Prone is little better because as we discussed, this iliac crest will not come in our view. Either we can come from inferior or middle calyx. We can clear maximum.
Overall inferior calyx is bad for supine, but
Yes,
when it is good, inferior calyx is good for supine when
if the kidney is high lying and there is a lateral component in the inferior calyx, we can
Correct.
easily puncture. And
Correct.
from lower to going upper calyx is very easy in supine PCNL.
Correct. So if the kidney is high, if the lower calyx is lateral,
yes,
you can reach all the calyces with lower calyceal puncture in supine.
Yes, sir.
So RGP is very important, na?
Yes, sir.
If the kidney is high, you prefer supine. If the kidney
Yes,
is very low, you prefer prone.
Prone PCNL.
Now, what about large stone in the middle, large stone in the pelvis, large stone in the upper?
I'll prefer prone PCNL, sir. I can come directly from superior
Multiple
calyx.
large stones, you will prefer prone.
Yes, sir.
Large stone with multiple small, you will prefer
Supine PCNL.
supine. What about Staghorn calculus? What will you prefer?
Staghorn calculus, I'll show in few RGPs, sir. Both can be done. Supine and prone can be done. But I'll prefer prone superior calyceal axis. Because I look all the time down and I can clear the stones. From superior calyx, it's easy to reach all the calyces. At one go, we can clear, especially if the kidney has large infundibula, wide infundibula.
What about the stone which cannot be done by supine PCNL?
There are the few conditions like superior medially located stone, superior calyceal stone, if it is medial and diverticular stone, or else medially located inferior diverticular stone.
Yeah.
These two conditions are difficult with supine.
Very medial upper calyx, very medial lower calyx, directed vertically down or up, supine is very difficult.
Very difficult.
What are the conditions? Supine is very useful.
Supine is very useful if the like the kidney has bifid or trifid system, very
Correct.
long narrow infundibuli,
Okay.
and if the patient is having any cardiorespiratory problem,
Correct.
then and the patient positioning cannot be done in prone like kyphoscoliosis
Correct.
and any single functioning kidney.
Multiple medium-sized stones.
Multiple medium sized
You
in
can
all
put them
cases.
into, all you can put them into the pelvis and you puncture with the supine PCNL and remove.
Yes, sir.
Multiple small anyway RIRS will be done.
Yes,
Now
sir.
can you go ahead with if the stones are in the lower ureter, mid ureter, upper ureter and the kidney, what will you prefer?
So if the stones in ureter, then I will prefer supine PCNL.
Because you
it
can
is
go from below and above. If the
above.
stone goes up, you can do supine. If the
Yes, sir.
stone comes down, you can do URSL.
Yes, sir.
What is the condition where this type of stones will be there? Lower, middle, upper, and kidney stones.
So,
Retained stent.
yes, sir. That
Retained
in that
stent, you have
condition.
to do cystolithotripsy, ureteroscopic lithotripsy, RIRS lithotripsy, PCNL lithotripsy. Ideal case for
ECIRS.
ECRS and supine PCNL.
Yes, sir.
It is now you share the clinical serials and quickly
Yes.
finish. We have short of time because
Yes,
the
sir.
voice was not good. Now
Yes.
I have repeated this. You can share and present.
So coming to the clinical conditions we discussed, sir, is my screen visible, sir? Now?
Yes.
So here there is a inferior calyceal stone. So both can be done. Here you can see, sir, supine PCNL, there is a clear lateral part.
Yeah.
We can puncture it and we can clear the stone.
Yeah.
Same is good prone anyway. The iliac crest will not come in view. We can puncture directly and clear the stone.
Correct.
So coming to the next case.
Yes. Move the screen.
Yes, sir. It's
And
not.
then, yeah.
Sir. So
Yes.
coming to the next case, this case, as you can see here, sir, there is a medially, vertically down facing lower calyx here. This is very difficult to puncture in a supine PCNL.
Correct.
In both the stones. This we have to better to do prone PCNL. But
Correct.
in this case, we have done supine and taken help of flexible scope to clear these stones.
Unnecessary extra cost now.
Yes, sir. Yes, sir. Prone is better.
Two monitors should be there, but it can be done with supine. But
Yes,
ideal is prone.
Yes, sir.
Next.
So middle calyx, it doesn't matter much. If it is pelvic stone, we can come from in prone or in supine. It doesn't matter much. We can come from middle calyx, but middle anterior calyceal stone supine is better.
Correct.
Because there will be less chances of bleeding.
Okay.
And coming to the superior calyceal stone, here there is a big pelvic stone, supine PCNL, supine puncture done. Always the puncture is to the laterally located calyx.
Correct.
So it is safe, but vertically down, the puncture is in prone PCNL, it is vertically down. Here what happens sometimes, if the kidney is non-dilated superior calyx, we may puncture the infundibulum directly.
Yes.
Then
Whereas in
the
supine PCNL, infundibular puncture is less.
yes.
Correct.
So in superior calyx, below the infundibulum, just behind the posterior segmental artery will be there. That will be disaster.
Correct.
So that condition we have to be careful. But in supine PCNL, superior calyceal puncture, always it is peripheral, though the tract length is little longer.
Correct.
Coming to pelvic calculus, easily we can come from either middle or lower calyx and we can clear easily, no problem. There is no much difference between prone and supine PCNL. So coming to the combination of stones, if there is a stone in inferior calyx and pelvis, this is the prone PCNL. We are coming from inferior calyx because the iliac crest is not coming in our way. And here again the same stones, but there is a clear lateral part of inferior calyx.
So if the lateral part of the inferior calyx is there, supine can be attempted.
Supine done.
A lot of advantage.
Yes, sir. Because we can go from the lower calyx to, if stone migrates to superior calyx, then we can easily travel from here to there.
Correct. Okay.
Yes, sir. Then coming to any stagon stone, like both pictures, this is prone PCNL done. Stagon stone, superior calyceal axis is better. We'll always look down and we will be able to reach all the calyces from upper calyx. Whereas in this case,
is this case done by you or somebody else has done?
No, this is done by Harshvardhan Tanwar, sir.
Okay.
Prone
So
PCNL, sir.
thank Harshvardhan Tanwar.
Yes, sir. Yes, sir. I thank him for all his RGPs, prone RGPs, because last 3 years I am doing only supine cases.
Okay.
This case is done by me, sir, supine PCNL stagon stone. So this case, we can see void infundibula is there. From inferior calyx, easily I could reach all the calyces and we could clear the stone.
Correct.
So if there is this medially facing is difficult. If there is lateral component, we can clear the stone.
Correct.
So again, this is again one more stagon stone, but both these cases are supine PCNL. Just to show the differences, we can come from superior calyx like this and clear all the stones. And this case done recently, we can come from inferior calyx and clear all the stones, provided lateral component should be there.
Yes. So ultimately, lower calyx should be high and lateral.
High and lateral, yes sir.
For supine.
Supine PCNL.
Lower calyx is more high above the iliac crest, more lateral.
It is good.
Easy. Otherwise, very difficult.
Very difficult, sir.
Right.
Sometimes if we come more laterally and towards the thigh, we may puncture the colon also in supine PCNL.
Correct, correct.
So going above the posterior axillary line.
Should not come so much anterior.
Yes, sir, yes.
Correct.
Then what are the advantages of supine PCNL? If the patient is too much obese, like this case, patient was 125 kilo and BMI 42, then to reposition the patient in prone, again, it is very difficult.
Correct.
Here it is easy. In supine, we need not change the position. Then as I told, in any emphysematous pyelonephritis case, this patient has low BP, saturation was not maintaining. We had to do PCL, supine PCNL we did ultrasound guided and patient did very well. Then coming to supine PCNL kyphoscoliosis, this position is difficult in prone PCNL and there will be very limited working space. We can take up help of ultrasound for puncture and guidance. This case, supine PCNL is very helpful. Then coming to supine PCNL in solitary functioning kidney, this patient had is a recurrent stone former with long narrow infundibuli and stones in upper calyx and lower calyx. But he didn't want to puncture the kidney with multiple punctures. So we did inferior calyceal puncture and took help of flexiscope and we could clear it. So we avoided multiple punctures. Here it is absolute indication for supine PCNL. Am I audible, sir?
Yes, yes.
Yes, sir. Then ECIRS in complex anatomy cases. This, as you can see here in RGP, these branching calyces, trifid system, and all calyces are having stones, and all are like medium-sized stones, more than 1.5 centimeter. We cannot take help, like we can take help of flexible scope, and we can fragment from middle calyx, and we can give to the nephrostome, so that extra punctures can be avoided. This is a case of bifid system. Again, we came from a superior calyx and we could clear this pelvic stone, and this small inferior calyceal stone we took help of flexiscope to clear. This is again classical example of bifid system. You have to puncture both the system to clear the stones. But if we have in supine PCNL, we can take help of flexiscope and clear these stones.
Yes. Bifid system, trifid system, small stones, always supine and ECRS is better.
Yes, sir.
Correct.
This case coming a trifid system. In fact, this case I was doing, there was a stone here and in inferior calyx. So I thought we'll puncture this calyx and could clear both stones. But ultimately, after dilatation, this big stone migrated to here. Here we can see here.
Yeah.
Then again, I had to puncture this also.
Okay.
But we can take help of flexi and clear it. Anyway, in bifid or trifid system, ECIRS is better.
Correct.
You can see here, long narrow infundibuli. Stone, while fragmentation also, it can migrate up like this. Then it is difficult to do puncture, extra puncture for a small stone. We can take help of flexi and just bring the stone and give it to the nephrostome tract.
Correct.
So this is a big stone in pelvis with all calyceal stones, all medium-sized stone in all the calyces. So we did supine superior calyceal access, could clear all the stones. But for this calyceal stone, I had to take help of flexi, middle calyceal stone.
Correct.
So this is again an example of the ECIRS. This is the superior calyceal. The superior calyceal is being long, narrow infundibulum. Either we have to do again one extra puncture for this, but I took help of flexi and fragmented and cleared with a single puncture.
Correct.
Again, this is long. If the kidney is superior calyx is having long, narrow infundibulum, if any stone migrates like this here, we can take help of flexi, and the supine PCNL is extremely helpful in this case.
Very good. Correct. Any long infundibulum upper calyx is also, even if the stone is larger, sometimes Prone PCNL we have to go above 10th rib. That can be avoided nicely by middle calyceal puncture and then use flexi. and take
Yes,
all the stones down into pelvis and take it out.
Yes, sir. Yes, sir.
We do routinely like that. That is
Yes,
where
sir.
actually supine PCNL has a major advantage.
Yes, sir. Yes.
Correct.
This is a classical example of tripod system where ECI is extremely helpful.
Correct.
If
correct.
any stone from migrates like this, sir.
You can bring back a flexible stone.
Yes, sir. Yes, sir. Now coming to forgotten bilateral digestion, this case, this here ECI is absolutely necessary. We have to take help of, as you told while discussion, URS cystolithotripsy, then both antegrade and retrograde access is required. In supine PCNL, we can do it. We can do PCNL and we can do from below and we can clear the stone. If possible, in single stage also we can clear if the patient is stable. Or else we have to stage the procedure.
Correct.
Yes, sir. And this case, bilateral impacted upper uretary, mid upper ureteric stones. Here contrast will not go up. Then we have to take help of ultrasound guided access and antegrade flexible ureterorenoscopy. Then we could clear these stones.
Supine or prone better?
Supine is better, sir.
Because you have access from below, you have access from above.
Above.
That is correct.
Prone ECIRS is difficult. Prone position to pass.
ECIRS is difficult. Prone
Yes,
PCNL can be done, but by chance, if you wanted to manipulate from below, you cannot do. It's very difficult.
Yes, sir. Very difficult, sir.
Split leg prone ECIRS is there, but it is not practiced routinely.
Yes, sir. Yes, sir.
Correct.
So to conclude, in most of our cases, case scenarios, prone is better. But in certain conditions like this, if the kidney is having long, narrow infundibuli and single functioning kidney and any forgotten digestion with stones in the ureter and in the kidney, large volume stones, we think supine PCNL is better and ECIRS is helpful.
Correct. Wherever RIRS is added, supine
Yes,
PCNL you have to learn. Do you recommend to learn both the cases?
Yes, sir. Because as we discussed, yes, sir. Both are essential, sir.
Better to learn both of them.
Yes, sir. Better to learn both of them because if any stone is there in medially superior medial diverticular stone.
Can you close the screen?
Yes, sir. Yes.
Do you recommend to learn both supine and prone?
Yes, sir. Both required, sir. Because
somebody says that I never required supine. Is it correct?
No, sir. No, sir. Because some cases, like the last case we discussed, if any patient comes with forgotten digestant, you have to, if you prefer only prone, then you have to do multiple times. You have to change positions. You have to clear with up and down. That is, and if the patient is CKD and having any cardiorespiratory problem, then difficult. ECIRS is extremely helpful in these cases.
Okay, if somebody says that supine I can do anything, is it correct?
No, sir. If the stone is in superior or inferior calyx, medially located diverticular stone, then it is difficult. We can never reach the superior medial stone, sir.
Very difficult.
Because we have to puncture in prone position only, direct puncture, and we can clear the stone.
Correct. So medial diverticular stones are medial impacted stones. Yes, low-lying kidneys. Yes, supine is very difficult.
Very difficult.
Radiation, do you think supine prone some difference?
Yes, sir. Radiation exposure is very less in supine PCNL because we will stay away from the patient.
But majority of the PCNL surgeon doesn't use CM that much, except the juniors.
Yes,
so
sir.
it not matter, or you can stand away also.
Yes, sir. And one more thing in supine PCNL, the fragments come out of its own.
Do you think that RIRS has to also to be learned?
Yes, sir. RIRS also is necessary, sir.
100%.
100%.
So RIRS, prone, supine, all must be learned. There is no surgeon like supine PCNL surgeon or prone PCNL surgeon or RIRS surgeon. So for all practical purposes, better to learn all the procedures. So with this, sorry for the inconvenience in the first 15 minutes where voice disturbance was there. And I appreciate Rakesh taking initiative for last 1 month, repeatedly asking and then trying on the CM and then this coin method, everything he put his efforts. So I appreciate Rakesh. Sooner we will have one more session on the RIRS, where RIRS is very useful than prone and supine.
Yes, sir. Thank you so much.
All the three we will discuss. Thank you very much.